Hi everyone, welcome back to my channel. My name is Dr. Nkiruka Bridget at OBGYN Talks with Dr. Ada Zion. I'm on YouTube. Please, if you have not subscribed to my YouTube page. Follow me on Facebook at OBGYN Talks with Dr. Ada Zion. Today I'll be discussing uterine fibroid. Uterine fibroid is also known as leiomyoma. It's also known as fibromyoma or just myoma. It's a benign tumor of the uterus. It comprises of smooth muscle majorly and sometimes may contain connective tissue. It's the commonest benign tumor of the women, especially the reproductive women. It's said to occur in about 20 to 25% of reproductive women, and as the woman increases in age, the increase, the recurrence, its effect, its occurrence also increases. So to have even about 50% in the fifth decade of life. The cause of uterine fibroid is not known. However, a genetic predisposition has been postulated because some cytogenetic occurrences have been seen in people that in uterine fibroid. The exact cause of uterine fibroid is not known. However, there is a genetic predisposition to uterine fibroid, but the familial inheritance, the exact familial inheritance has not been well established. There is cytogenetic abnormalities on chromosome 6, chromosome 7, chromosome 12, and chromosome 14. These have been postulated to be seen in uterine fibroid, in women with uterine fibroid. Also, there is presence of mutation on cell growth, that is smooth muscle growth. The effect to regulate smooth muscle growth. Remember, we said that uterine fibroid is from smooth muscle. So regulation of smooth muscle growth is abnormal, and so because of mutation, the smooth muscle tends to grow on its own, overgrowing the other surrounding smooth muscle, and is postulated to be the exact cause of uterine fibroid. Now, uterine fibroid is divided into types depending on the location of the fibroid. We have the one we know as submucous fibroid. Submucous fibroid is when the fibroid is located into the endometrium. Endometrium is inside the uterus where the baby lies, the location for the conception and pregnancy. So any fibroid located into the submucous is known as submucous fibroid. We also have intramural fibroid or interstitial fibroid. Between the submucous and the outside of the uterus is the muscle, the smooth muscle, the muscle that helps to hold the uterus. So any fibroid located in the that muscle is known as intramural fibroid. Then the one fibroid outside the uterus, the one outside, just like in the picture I'm showing above, the one outside is known as subserosa. If the one outside has a stalk on its own, we call it pedunculated. Fibroid can also be in the cervix, the entry to the uterus, that is the mouth of the uterus. If there's a fibroid at the cervix, we call it cervical fibroid. We can even have parasitic fibroid, when the fibroid, especially pedunculated fibroid, has detached itself and gets implanted into other surrounding structures, getting blood supply from those structures. When you see the tumor, it's no more on the uterus, it may be on the omentum because it's already getting its supply from the surrounding structure. So we can have parasitic fibroid. These are just types of fibroid depending on the location. Now, risk factor. What's the risk factor for getting uterine fibroid? Remember, I said the exact cause is not known, but there are risk factors to uterine fibroid. In a woman that has not had a baby before, we call them nulliparous women, nulliparity. For someone that has not had a baby before, she's at risk of having uterine fibroid. There's this saying that presence of uterine fibroid is a compensation to the uterus for not carrying a baby. So when there is no baby in the uterus, a fibroid may stay because the uterus wants to actually carry something at a time. So that's the saying. Nulliparity is a risk factor for uterine fibroid. Then other risk factors include obesity. Someone that has body mass index greater than 30 is an obese individual. So obesity, how does obesity cause uterine fibroid? It's postulated that, in obese persons, there are increased fat cells. These fat cells are converted to cholesterol, and this cholesterol are acted upon to estradiol, and this estradiol actually helps to feed uterine fibroid. So obesity is a risk factor for uterine fibroid. Then advanced maternal age, just like we said, if there is no baby, a fibroid, another tumor will want to stay. So someone that is advanced maternal age, there's someone that is having her first baby around 30 years, 35 years, be rest assured most times that a fibroid is already occupying that uterus, because it's a compensation for a uterus not carrying a baby. Now, other risk factors include some people that see their menses even before 12 years. So there are risk of uterine fibroid. Then the race, black race. Remember we said there is a genetic predisposition. Black race, those that are of African descent, are said to have uterine fibroid more than Caucasians. So, but a factor that actually reduces the risk of uterine fibroid is said to be smoking. However, when you smoke, you weigh the risk and the gain. So if the risk outweighs the benefit, you should know that smoking may not be good for your health. Now, what are the clinical features of uterine fibroid? The clinical features of uterine fibroid, most uterine fibroid are actually asymptomatic. Asymptomatic means that it does not give any symptom. However, when there is presence of symptom, you start seeing something like abdominal swelling, especially when the uterine fibroid start growing. It will not leave the pelvis and it will be palpated on the abdomen. So it becomes abdominal. And the person will be, for some women, will be thinking they are pregnant, not knowing that it's just uterine fibroid. Then also, for those that have symptoms, you may start having irregular menstrual bleeding. Sometimes their menses will be, instead of the normal 3 to 5 days menstrual flow, they will be having up to 8 days menstrual flow with passage of clot. There may be fainting attacks, syncope for someone that have heavy menstrual bleeding. So the menses will become so big and will be giving discomfort. In some people, the menstrual cycle length, that is the cycle length from one menses to another, is decreased because of the effect of the uterine fibroid on the endometrium. So they may have increased bleeding. This may predispose them to frequent hospital visits and blood transfusion. When there is pressure symptoms on the uterine fibroid, you see the person coming with constipation because the size of the uterine fibroid may be impeding on the rectum posteriorly, and so physics may not be able to pass. The person will come with inability to pass physics, that is constipation. The person may also come with urinary frequency. When the fibroid is pressing on the bladder, the capacity of the bladder is reduced, so small volume of urine inside the bladder, the person goes to wee. Small volume of the urine inside the bladder, so urinary frequency, the person will be urinating frequently. And some may even have occlusion when the urethra is already occluded. So urine in the bladder may not be able to pass. And with effect on the bladder, there may be stasis and backflow. So when there is backflow into the ureters, the person may not come with hydroureters, and the next thing is that the person may have kidney failure. So it can cause pressure symptoms. It can even lead to heartburn when its effect on the intestine. The person will be having frequent heartburns. So there may also be leg edema. When the uterine fibroid is impeding on lymphatic drainage, the fluid will tend to accumulate on the lower lymph, and the person will come with leg edema. Uterine fibroid may even cause abdominal swelling, that is fluid in the abdomen. We call it ascites. Now, how does it do that? If there is a subserosal fibroid, it may cause irritation of the peritoneum, and because of the irritation of the peritoneum, fluid will be accumulated into the peritoneum. We call it MERS syndrome. The person will come with ascites, with fibroid, and you're not seeing any other reason for the ascites apart from the fibroid. So, uterine fibroid may present with some bizarre symptoms. It can even lead to what we call polycythemia because of its effect on the kidneys. The kidneys tend to increase production of erythropoietin because it's feeling that there is anoxia. Something is impeding blood supply and oxygen to it. So it feels the person is not having enough blood, not knowing that it's the pressure of the fibroid, and the person will now start presenting with polycythemia. So can be anemia, it can be polycythemia, depending on the one the person is having. If the person is having excessive vaginal bleeding, the person will come with anemia, no blood, and will require multiple blood transfusions. So uterine fibroid, when it becomes symptomatic, something has to be done to prevent adverse sequelae. What are the investigations that can be done? A common abdominal ultrasound will go on to find the uterine fibroid. From the history the person presents with, you can do an abdominal ultrasound and it will show you that this person, there is fibroid. And it will even tell you the exact location of the fibroid. Then CT or MRI can be done, especially if you are thinking of sarcomatous changes, if you are feeling that there is this fibroid, though rarely, is becoming cancerous. So you can do this to give you, this is no more fibroid, you think is becoming cancerous. Then you can do ordinary packed cell volume or hemoglobin estimation. For someone that's presented with increased bleeding, she may come with anemia, and doing a packed cell volume will show you that this person is really anemia and needs help. Other investigations that can be done include intravenous urography. For if you are suspecting that the fibroid is impeding or occluding the ureters, you may want to see the patency of the ureters, if there's occlusion, if there's hydroureter, and if you are planning for surgery for a huge fibroid, you may still want to do IVU, that is intravenous urography, to study the cause of the ureter so that you don't injure the ureter during surgery. Now, you can also go ahead to do hysterosalpingogram, especially for medical legal reasons. There are some fibroid that will be occluding the tubes, and if you go on to remove it, especially for those seeking to have babies, and the tubes are occluded after the surgery with adhesions, you may be held responsible that you are the cause. So fibroids, especially for huge fibroid, hysterosalpingogram is needed to find the patency of those tubes, to find if their tubes located at the corner end or in the fallopian tubes that may cause occlusion and prevent fertility, so that even after the surgery, you'll be able to say, initially before this is what we saw, and we are able to correct it, or we're not able to correct it, that it's still the same. So these are the investigations that can be done for uterine fibroid. What are differential diagnoses for uterine fibroid? When you have uterine fibroid, because it causes swelling, abdominal swelling, the person may think, I'm pregnant, and when it's actually not pregnancy, because the amenorrhea, that is absence of menses that follows pregnancy, may not follow uterine fibroid. Then ovarian tumor, some people will say it's ovarian tumor, those that don't even know what ultrasound, some people that are not well skilled in ultrasound, pick other things, not knowing that it is uterine fibroid, especially for pedunculated fibroid that is already impeding on the adnexia. So the person may think it's ovarian tumor. Amongst other differential diagnoses, what is the treatment of uterine fibroid? This treatment of uterine fibroid can be conservative, it can be medical, it can be radiological, it can be surgery. The surgery can be open surgery or laparoscopic surgeries. So conservative management for those with uterine fibroid that are asymptomatic, it's not giving them any symptom, it's not palpable, it's not in the abdomen, there is no abdominal swelling, there is no pressure symptoms. Leave the fibroid alone. Most times we leave it alone. So that is conservative management. You observe, reassure the person, and allow her to live a normal life. But for those that have the fibroid is symptomatic, you can go on to can advise the person for medical management. There are some drugs we give. First of all, to control bleeding, in excessive bleeding, we can give some hormones to shrink the fibroid, especially in those that are perimenopausal, those that are about to enter their menopause. We advise them, okay, since you're about to enter menopause, there may be no need for surgery, especially if the fibroid is not too big, because with the cessation of menses, estrogen level is decreased, the fibroid tends to shrink. The hormone feeding it is depleted, so the fibroid itself will shrink. So we're going to give the people medical drugs. But for a younger person, after 6 months of using that drug, the person may start feeling some postmenopausal symptoms. And so we can add back, we call it add back, we can give another hormone so that the person will refresh herself. But for those that are perimenopausal, we can use the drug, hoping that soon they will enter their menopause. It does not remove the fibroid, rather it shrinks it. Another disadvantage of using that drug in someone that are going to plan for surgery is that it may not allow us to appreciate the fibroid when we are trying to enucleate it, to remove it during surgery. So that is the disadvantage using it to a younger person that will still go for surgery. Now, radiological intervention. There is use of uterine artery embolization. This is radiologically done through the femoral artery. You get to the uterine artery and you pass the things you're going to use to embolize it. What we do, we knock off the blood supply to that fibroid, and the fibroid tends to shrink. Then we can do high intensity focus ultrasound. What it does is that it takes thermal energy into the body of that fibroid, and after that is done, give it some time, the fibroid will shrink. That is radiological. Now, when we come to surgical procedures for uterine fibroid, it can be laparoscopy, it can be hysteroscopic removal of fibroid, or it can be open laparotomy, that is open abdominal surgery. In most in the tropics, because of cost and skills, most symptomatic fibroid goes through open abdominal surgery, and there is good outcome in most of them. However, for minimal access surgery, if the fibroid is submucous, hysteroscopy can be done. Use of hysteroscopy to remove the fibroid. If the fibroid is on intramural or submucosa, laparoscopy can be done and used to remove the fibroid. However, in most hospitals in the tropics, in the third world country, where there is minimal access to laparoscopy or hysteroscopy, open abdominal surgery can be done. If the surgery is submucous and intramural or pedunculated, the fibroid will be removed and everything is fine. But if the fibroid is submucous, that is where the baby lies. After removal of that fibroid, we tend to reconstruct the endometrium, especially for those that still want their fertility. We tend to reconstruct the endometrium and pass what we call intrauterine catheter and give the person hormonal drug to keep the endometrium patent so that adhesion does not grow in between. Complications that may follow with submucous myomectomy. Myomectomy is removal of fibroid. Is that if these things I just said is not done, adhesions may grow in between the lumen of the uterus and it will close together. The person will start seeing scanty menses or may not be able to see her menses anymore. Uterine fibroid is something that can be managed. There are a lot of myths in the tropics about uterine fibroid. Some people have been told that they will put something in their private part, in their vagina, and they will bet the fibroid. It is a lie. There is nothing you put on inside the vagina to bet the fibroid. However, or what will occur rather is that thing, especially caustic soda, which is put inside the vagina, may cause complications. It may cause what we call gynetrasia. The vagina gets closed up. It may cause vesicovaginal fistula. It may eat up the vaginal wall and the bladder, and the person will start leaking urine through the bladder. It may eat up the posterior wall of the vaginal wall and the rectum, and the person will start leaking feces from the rectum. It may cause the vaginal wall lumen to become fibrosed and the lumen become small, giving what we call gynetrasia. There is nothing like putting something in the vagina to bet the fibroid. Fibroid that can fall off on its own is submucous fibroid that are already pedunculated. When they overgrow their blood supply, they may become necrosed and shrink. And that will fall off, and you think the person has bet the fibroid. That is the only thing. There is nothing you put in the vagina to bet the fibroid in the tropics, please. Now, the second thing people are told is that there is a supplement you continue to take and the fibroid will fall off. It's a lie. People are trying to sell their market. Don't fall a victim for them. Come to the hospital and you'll be evaluated. If the fibroid needs to be removed, We will tell you the methods of removal and you make an informed decision. However, if the fibroid is asymptomatic and small and is not disturbing your life or your fertility, we'll reassure you and allow you. Pregnancy and fibroid can coexist. But if there is choanal fibroid or cervical fibroid, it may prevent implantation. It may prevent passage of the sperm to fertilize the egg. And it may cause the problem with the tube in picking the eggs. As you want. Thank you for watching to this point. Please, if you have not subscribed, hit the notification button right now. Subscribe to my YouTube channel. Follow me on Facebook page or at OBGYN Talks with Dr. Ada Zion. I'm also on Instagram and I'm also on TikTok. God bless you. See you next time for another enriching medical discussion. Thank you. I love you.